Alrighty, so welcome everyone to our third session of the day. I'd like to introduce Dr. Leslie Rudzinski, who is from the Queens Medical Center, and she had moved from Augusta, Georgia. She's a member of the American Epilepsy Society, a fellow of the American Clinical Neurophysiology Society, and a member of the Phi Beta Kappa and Alpha Omega Alpha. Her clinical and research interests include ICU, EEG monitoring, women's issues in epilepsy, autoimmune epilepsy, and disparities in epilepsy populations. She has published articles in peer-reviewed journals and book chapters and textbooks of ICU EEG monitoring. Dr. Rudzinski grew up in Centerville, Ohio as a scholar athlete and high school class valedictorian. She is married with children and enjoys spending time with her family, running, swimming, playing tennis, hiking in the great outdoors, traveling, reading, and cooking. So without further ado, I will hand it over to you, Dr. Rudzinski. Thank you for joining us.
Oh, thank you very much, Ron. Thank you, everyone, for joining us this morning. Let me see if I can share my screen. Or maybe, Ron, if you want to help me with that, because it doesn't
Sure.
seem to.
Yes, no problem.
Okay. There we go. Okay. All right. Does this look good?
Yes.
Hmm. Okay.
How does that look?
Okay,
Is that okay?
that looks good.
Great.
Okay. And then as far as advancing,
Yep.
let's see if I just.
You can let me know and then I can advance for you.
Oh, okay. All right. So good morning, everyone. Thank you for joining us on this Saturday. I appreciate all of your support. I'm going to be speaking about seizure rescue medications, what they are, and when to use them. Okay, next. Oh, there you go. Okay, it's down here. Okay, so the objectives of my talk are to define what seizure clusters are and discuss the newly approved intranasal therapies for seizure clusters and discuss the differences between the two new medications we have on the market now, Nasalium and Valtoco, and demonstrate how to use the intranasal device and put in a plug for learning seizure first aid and having a seizure action plan. Okay, next. Okay, so what are seizure clusters? Okay, next slide. So about 5% of patients, 5% of 3.5 million people with epilepsy in the United States have seizure clusters. So that's pretty large amount. It amounts to 170,000 people in the United States. And people that have seizure clusters have more frequent emergency department visits, hospital stays, and seizure-related injuries than those without clusters. And 1 out of 3 patients with clusters will have to go to the emergency department. Patients with clusters will have a 3-fold higher mortality rate than those without clusters. And strikingly, only 1 out of 5 patients, or 20%, currently take a rescue medication for their seizures. So that's quite a low and shocking number. Okay, next slide. Okay, so what are seizure clusters? So these are seizures that are different from a patient's typical seizure pattern. They're defined as basically 2 or more seizures within a 24-hour period or several seizures in a row. They may occur hours apart over the same day or over a span of 2 to 3 days. Most clusters will occur within a 6 to 12-hour period or a 12 to 24-hour period. And the seizure clusters may differ between patients in terms of how many seizures are in the cluster, what type of seizures They're having the severity of the seizures within the cluster and the duration of the seizures. So your neurologist or epileptologist can help you identify seizure clusters and when and how to use a rescue medication to treat them. Okay, next slide. So seizure clusters can lead to a lot of dangers and morbidity in patients with epilepsy, including those patients are at increased risk for having injuries and having hospitalizations. And these clusters may lead to status epilepticus, which is a seizure lasting longer than 5 minutes, or it's defined as frequent repetitive seizures which occur without the patient returning to his or her baseline mental status. So just like you need a fire extinguisher to put out a fire, which can rapidly spread, you also need a seizure rescue medication, which I call a fire extinguisher, to stop seizures from being prolonged, which is greater than 5 minutes long, or recurring within minutes or hours. So rescue medication gives patients and their families and caregivers, coworkers, and friends peace of mind and allows them to control, uh, have more control over their epilepsy and their seizures, to be able to stop a seizure in its tracks, and allows caregivers to live a life of freedom and to be able to go out and live life without the restrictions of worrying about having a sudden seizure. Okay, next slide. Okay, so what are we looking for in a good rescue medication? Well, we want it to work fast, so speed is very important. In addition, we want the medication to not be quite sedating, so it allow you to feel like yourself again shortly after taking it. And we also want it to be efficacious and effective in preventing additional seizures within the cluster. And we want it to be convenient. We want it to be given by anyone, anywhere. So it can be given by a non-medical person, caregivers, family members, coworkers. In addition, it's not really the drug that matters in this case. It's really the delivery system that is the most important. Okay, next slide. So you may have heard this, time is brain, okay? So you've heard this in the stroke world. You got to get the person to the ER quickly so that we can, uh, prevent the stroke from actually occurring and progressing. But we also use this term in epilepsy as well. And the use of seizure rescue medications is best if you use it within the first 5 to 10 minutes of seizure onset. And the sooner you use these medications, the better they are going to work. So we do know that the quicker treatment is given, the more likely the seizure will stop and not become prolonged and lead to status epilepticus. So if the seizure does continue for a lengthy period of time without medical treatment, there's a higher risk it will not respond to treatment with an additional 1, 2, or 3 additional medications given at a later time. And interestingly, they've studied this and they've looked at when patients' families call 911 for patients who are having a prolonged seizure or cluster. It takes EMS, takes the ambulance 42 minutes to arrive. So that's a long time. If the patient is having a seizure for that long period of time, that is a medical and neurological emergency. And then it takes a total of 56 minutes from the time of the seizure onset to the time they reach the emergency department, so almost 1 hour. So this is quite scary. If the patient is continuously convulsing for, a 40 to 60-minute period without medical treatment, this is not only a neurological emergency, but a medical emergency as well, and it increases the risk of having brain damage from the seizure, other severe life-threatening medical complications, as well as mortality, the risk of death. Okay, next slide. So benzodiazepines are a class of medications that have emerged as a first-line abortive treatment of seizures. And we're talking about prolonged seizures so more than 5 minutes long, seizure clusters, or status epilepticus. And we really got here after the VA cooperative study in 1998 compared 4 medications. So they put 4 medications head to head to see which would be the winner in stopping generalized convulsive status epilepticus. So where the patient is having a continuous grand mal seizure without stopping. So they compared IV lorazepam as well as IV phenytoin, phenobarbital, and IV diazepam given first, followed by phenytoin. And then what they found was that IV lorazepam performed better, so it was more efficacious than phenytoin. And compared to all the other treatments, it was the easiest treatment to use for stopping generalized convulsive status epilepticus. So since that period of time, benzodiazepines have been considered first-line treatments. But typically in the IV forms, and you can only get the IV forms when you come to the ED. So let me talk about benzodiazepines, or we call them benzos for short. They're a class of medications that increase the way the neurochemical GABA works in the brain. Now, GABA acts to suppress or inhibit the firing of certain groups of neurons in the brain. And we have several different types of benzodiazepine medications, including diazepam, lorazepam, and midazolam. The ones highlighted in purple are the ones that we use for abortive treatment of seizures. Now, in 1997, Diastat, which is the rectal gel formulation of diazepam, was FDA approved, and it was the first at-home treatment for seizure clusters. So that, at the time, was quite revolutionary because you could then treat these seizures at home instead of having to go to the hospital and get IV medication. Next slide. So I'm going to present a patient case of one of my patients just to demonstrate the efficacy of these new medications. So this patient is an 80-year-old active and healthy white male who had post-stroke epilepsy due to a right middle cerebral artery occlusion just a year ago. And his seizures consist of focal aware sensory motor seizures. So he will have tingling, starting in his left hand, followed by tonic-clonic jerking of the left hand, which may progress and move up into his arm and his shoulder, and may cause him to lose awareness. Now, he has typically quite prolonged seizures, lasting about 5 to 15 minutes per seizure. And he also has clusters. These may reoccur within hours. And he may have about one prolonged seizure or one seizure cluster every 3 months. That was his baseline when he came to see me. He required several trips to the emergency department, requiring 2 to 4 milligrams of IV lorazepam to stop his seizures. And because of the COVID epidemic, he was afraid to come to the emergency department. And so his wife had a prescription of rectal Diastat to give him at home. Okay, next slide. Okay, so rectal Diastat, although it's a wonderful at-home treatment, it is quite intrusive and embarrassing to use, as you can imagine, especially in teenagers and adults, or if you have to use it in a public place, God forbid. It does require, pulling the pants and the underwear down and positioning the patient, such that you can give the medication. So it is logistically challenging and perhaps socially not quite as acceptable. So in this patient, Diastat happened to be ineffective. His wife tried to use it at home, and he still had to go to the emergency department for definitive treatment. So when he came to see me, I prescribed him Nasolam, which is intranasal midazolam, which was the first FDA-approved drug for the acute treatment of seizure clusters in over 20 years. It was just approved in May of 2019. And we are very excited about this because we've been waiting for over 20 years for a new or different drug to use in an easier manner, if you will, than rectal Diastat. And up until this time, that was the only FDA option we had. So this is the first FDA-approved nasal option for treating seizure clusters. Okay, next slide. Okay, so I developed a seizure rescue plan with the patient and his wife. And so we talked about the fact if he has another breakthrough seizure, onset of left hand tingling, his wife will start timing the seizure at that point, and then she will go get Nasolam from the medicine cabinet. And if his seizure progresses to focal motor clonic activity, spreading up his left arm, and the seizures continued over about 3 minutes, his wife will administer 1 dose of Nasolam into one nostril and will repeat the dose in 10 minutes in the other nostril if he is still seizing. So the patient and wife were so happy. They had a chance to use Nasolam on one occasion, and it stopped his prolonged seizure and prevented a recurrence hours later. And he didn't have to go to the emergency department and risk COVID exposure. And he told me he took a nice nap for an hour and a half and then woke up feeling great and was back to his normal self. So now at home, they have several doses of the nasal spray. They have 1 in the medicine cabinet at home, 1 in the glove compartment of the car, 1 in the waist purse, and 1 in their pants pockets during hikes because they're quite active and they like to hike up on the Hawaii Loa Ridge Trail. And so they can have it with them as a sense of security. Should he have, a breakthrough seizure in a somewhat dangerous place. Okay, next slide. Okay, so now I'm going to talk about the 2 different medications that are approved for intranasal treatment for seizure clusters. The first one approved is Nasolam, and the second one just approved is Valtoco. So I'm going to talk about both of those. Next slide. Okay, so Nasolam is the first FDA-approved intranasal drug for acute treatment of seizure clusters. It was approved in May of 2019, and this is what it looks like. It's a prescription nasal spray, and it's rapidly absorbed into the nasal mucosa within minutes. It's considered a controlled substance of Schedule 4, and it's approved for patients 12 years of age and older. The half-life of this medication is short, so it's considered a short-acting benzodiazepine. So what half-life means is the time that it takes the body or the liver to break down a medication by half of its concentration. So the half-life of this is between 2 and 6 hours, so it's broken down pretty significantly within that time frame. The time to peak concentration in the bloodstream, if you measure it in the blood, it takes 17.3 minutes to reach its maximal concentration in the blood, which is quite quick. And the dosing is the same regardless of what age you are and what weight you are. So it's very easy. It comes in 5 milligram doses, 5 milligram doses in one of these nasal spray cartridges. And you can give up to 10 milligrams total, which would be 2 doses, which is the maximal dose. And if the patient is still seizing 10 minutes later, you can repeat the second dose in the other nostril if needed. Okay, next slide. Okay, and so Nasolam, if you get sedative effects or sleepiness effects, if they occur at all, they'll start beginning at 10 minutes after the dose and they'll peak about 30 minutes to 2 hours later. But the patient is typically back to baseline mental status in 1.2 to 1.5 hours. And that's important because then you can just go about your day. It doesn't wipe you out for the whole rest of the day. And then doctors have to use caution when we're using this with medications that are also metabolized by the cytochrome P450 system in the liver that are 3A4 inhibitors, because the half-life of Nasolam will be prolonged and it will increase the sedative effect. So with the medications listed below, just be careful with prescribing Nasolam with those, just be extra cautious. And the drug expires after 1 year. And it's good to consider using this in people with rapid clustering, perhaps within a 6-hour period or so. And its efficacy was recently proven in a phase 3 randomized double-blind placebo-controlled trial of 201 patients. And the primary outcome measure of the study was stopping the seizure cluster after 10 minutes or within a 10-minute period without recurrence of any further seizures within the cluster up to 6 hours. So 34% of patients in the placebo group had their seizure cluster stopped within 10 minutes, and 54% of patients had seizure clusters stop after 10 minutes. And so this was considered clinically significant with a significant p-value of 0.01. Okay, next paragraph. Next slide. Okay, and then they followed this up with a NASALAM open label extension trial of 161 patients, which basically means that the patients, they all had epilepsy and they all knew what they were getting. They were getting NASALAM. And the most common side effects that they noted in this study was nasal discomfort in about 12.4%, sleepiness in 9.3% of patients, and headache. And again, treatment success was defined in the same way. Seizure termination within 10 minutes without recurrence up to 6 hours. So 55% of patients had treatment success after the first dose of NASALAM, followed by 80% of patients with treatment success after the second dose. And 40% of patients did require a second dose of NASALAM. Okay, next slide. Okay, so the most common side effects of NASALAM as reported by UCB in their data included sleepiness. 10% of patients were sleepy versus 4% of placebo patients. Headache, runny nose, nasal discomfort. Interestingly, the nasal discomfort was lower in percentage than with the placebo at 8%. Throat irritation, and being aware that you can have impaired mental alertness and memory problems short term after giving the medication. Okay, next slide. Okay, so now I'm going to talk about Valtoco, and this is Valtoco. So it looks predominantly the same. If you can see on the camera, it says Valtoco. So this is the second FDA-approved intranasal drug for the acute treatment of seizure clusters. It was approved in January of 2020. And this is also a prescription nasal spray, controlled substance, Schedule 4. But this one is approved for younger patients, 6 years of age and older. So if you treat pediatric patients, this is good. This is a long-acting benzodiazepine as opposed to NASALAM, with a half-life being 49.2 hours, so 2 days at the 10 milligram dose. So it takes 2 days for the concentration of medicine to be broken down by half. And it reaches its peak concentration in the blood within 1.5 to 2 hours. And with this medication, doctors have to be aware to also use caution with if you're prescribing this in patients who are already on cytochrome 3A4 inhibitors and cytochrome 2C9 inhibitors. So I have a list of 2C9 inhibitors there, which those medicines we don't use very commonly, but it's just good to know. So the dosing of Valtoco is based on weight and age. And it's important to know that if patients are already on Diastat and you'd like to switch them, you do a direct one-to-one conversion. There's also a dosing card online, and then it will give you the exact dose of patients ages 6 to 11, which is 0.3 milligrams per kilogram. And then in ages 12 and up, you do a little bit lower dose of 0.2 milligrams per kilogram. And it comes in 5, 10, 15, and 20 milligram doses. You may redose this medication and give a second dose if needed with 4 hours later into the other nostril, and the drug will expire after 27 months, I believe. So Valtoco is clinically superior to Diastat, the rectal version of diazepam, due to less pharmacokinetic variability. And what that means in layman's terms is that you have more steady, reliable, and consistent drug levels between patients than you do with Diastat. And compared to Diastat, there's much less somnolence or sleepiness at a rate of less than 2% compared to 23% as seen in Diastat. So the level of sedation we're talking about is awake and talking, but somewhat drowsy. And you're less likely to need a second dose within 24 hours because the drug concentration will stay high enough to prevent seizures for the first 6 hours after drug administration. In the studies, about 86% of patients did not need to have a second dose within 24 hours. And the most common adverse side effects were nasal discomfort, congestion, a little bit of a bloody nose or abnormal taste. And when they talk about level of sedation in this study, they're talking about low levels of just transient sedation, so not too significant. And in the recent open label phase 1 study of 57 patients just published this year, which included children, the most common side effect they had were abnormal taste and nasal discomfort. But in that study, they did not find any changes in respiratory rate or clinically relevant changes in sedation, smell, nasal irritation, or nasal mucosal pain. Okay, next slide. Okay, so I'm gonna, this is the last portion of the talk here, and I'm gonna talk about how to use Nasalium and Valtoco. I want to remind you that the website's there. You can just go to those website addresses, and it will give you everything you need to know about the medication, including videos and instructions about how to use it. Okay, next slide. Okay, so the first step here would be to hold the device with your index and your middle finger here, and then your thumb is on the plunger here, okay? And the important thing to remember at step 1 is to not deploy the dose of medication, so don't test it because then you're gonna lose the dose completely. So it's already in there, okay? And then next slide, second step. You place this in the patient's nostril, and you go all the way up to where your fingers touch the nose. So you get it in there, and then next slide. So once you get it in there, and then you just press the plunger like this. That's it. And so the patient does not have to inhale this. They don't have to be, you know, breathing. They don't have to breathe it in. It automatically goes in and gets absorbed in the nasal mucosa. Okay, next slide. And then I just want to review serious class side effects with both of these medications and cautions. So please do not use these if the patient is already on other benzodiazepines or opioids, barbiturates like phenobarbital, and don't use with alcohol because it will increase the risk of respiratory depression. That is airway obstruction, or the breathing becomes very shallow, slower, or may stop completely, leading to low oxygen levels in the blood, or it can prolong the effect of the drug. So just be very careful, especially in using this with opioids. Suicidal thoughts and actions are quite rare, and it's sort of a black box warning, but it did not occur in any of the studies. And it's completely contraindicated in patients who already have an allergy to midazolam or diazepam, or if they have acute narrow angle glaucoma. So this can be used in patients with open angle glaucoma if it's treatment, because this can increase the intraocular pressure in glaucoma patients. Okay, next. So this is a summary table basically about everything I talked about, like discussing the differences between Nasalium and Valtoco, and there's not one right or wrong answer here as far as choosing which medication, but it's just good to know the facts. So with Nasalium, you can use it in patients 12 years old and up, Valtoco 6 years old and up. Their time to maximal concentration is different. Nasalium reaches peak concentration in 17 minutes. Valtoco reaches peak concentration in 1.5 to 2 hours. The half-life of Nasalium is about 2 to 6 hours, so it's rapidly cleared from the body, versus Valtoco, which lasts for about 2 days. And then if a patient is on a 2C19 inhibitor, like another medication, you don't have to really worry about that with Nasalium, but use Valtoco with caution in that scenario. If this patient has seizure clusters that are shorter in duration, like over a period of several hours, Nasalium may be the way to go, but if they have longer seizure cluster durations, like over a period of multiple hours or even days, then you're going to want a longer acting medication, so that you might want to choose Valtoco in that circumstance. And if they have an allergy or intolerance to any of the medications, then if they try one and they have an allergy or intolerance, you can switch them to the other one. And then just know that with Nasalium, you might need to redose. So you might need to use a second dose, maybe 40% of the time. Valtoco, most often, in at least 86% of patients, you don't need to redose it within the first 24 hours. So only one dose there. And then also based on insurance coverage, what they, which drug they cover based on your insurance plan. Okay, next slide. Okay, and then no talk on seizure rescue medications is complete without reiterating the fact that seizure recognition and first aid certification is now available. So you can actually get certified in seizure first aid. So I'll put in a plug for going straight to just epilepsy.com. It's on the front page. You just go to that, you click on take a training right there, and then it pulls up the number of trainings that are occurring this month. And I believe they're all webinars, and it's very easy to register. You just click on the link and fill out your information, and boom, you're registered. So I really encourage people to do that, including caregivers or pretty much anyone who takes care of patients with epilepsy. Okay, next. And then the last thing I want to talk about is seizure action plan. It's important to have one of these in case, like for home, for school, for workplace, so that caregivers, teachers, coworkers, friends can know what to do in case somebody gets into an emergency situation with a prolonged seizure or status epilepticus. So to find this, it's like a 2-page PDF form. Go to that link, epilepsy.com, click on Learn, and then click on Managing Your Epilepsy, and then go to Management Tools and click on the link Seizure Action Plan, and it's a direct link to the PDF form. So you can just fill this out, and you can leave it at home, give it to your school nurse, give it to your coworkers at work, just in case you get into an emergency situation. And it gives explicit instructions on what to do. Okay, next slide. Okay, and I want to gratefully acknowledge the support of UCB and Neurelis for sponsoring this symposium. And again, for any information, so many tools, resources, go to epilepsy.com. And I think that's it. Next slide. And thank you so much for your attention, and